World Kidney Day lecture by Dr. Ebun Bamgboye, consultant nephrologist at St. Nicholas Hospital.
Good days afternoon now, and I really must thank all the senior citizens that came here who have graced this occasion. And I really thank you for obliging us with your presence. I know that there are quite a number of people online because really this is a very important thing that we all should know about. The kidneys, though they're small, it's amazing how much function and how much of a role they play in our well-being. And unfortunately, when they don't function properly, it's incredible the amount of malfunction the whole body has as a consequence. So over the next 30, 45 minutes, what I'm going to try and do is give us a crash course about the kidneys. Tell us what they're about. Tell us how much of a problem kidney disease is in the world, specifically in Nigeria today. Take us through the things that very commonly can cause kidney problems. And in the process, hopefully also how we can prevent those things, if we have them, from causing us to have a kidney problem. Then we'll talk about the options for looking after kidney problems. And then you'll find that just like every other thing in the economy of Nigeria today, it's quite expensive to manage kidney problems when they. That's why it's better to prevent. Because when it then occurs, the amount of money that you will expend trying to control it is very often beyond what every layman or common man on the streets can look at. And that really is the focus for the World Kidney Day this year. How can we, what are the things that we as individuals, what can the different associations, what can government do to make sure that the common man doesn't develop kidney problem? When he develops it, how can we identify that he has it? Then how can we help such people manage the problem? You find that the overarching theme is advancing equitable access, care, and optimal medication. I mean, this morning I was speaking with one of my patients. He had a transplant not very long ago. He tells me that even after the transplant, having to spend over 300,000 every month just to maintain that. How many people earn that in a month to now be able to afford to spend that just to. So I'm going to go very quickly. I see you're quite an enlightened audience. So I will make sure that I speak to everybody who's here. We all can understand. For those who are online, please mute. Right. This year, the theme is Okay, this year the theme is advancing equitable access to care and optimal medication practice. And it's like it's a way of looking at how we can help people who have your access care. Now, St. Nicholas has been in existence for almost 60 years. But at least for 25 of those years, we've been noted after patients. We found that we actually pioneered kidney transplants about 25 years ago. Of course, before that, dialysis, all those other aspects of care. Get to know we've done over 400 transplants. But let's meet of why we're here today. That's about kidney disease. It's a very common problem. And we estimate that over 10% of any population in the world have some aspect of kidney disease or other. So if you estimate it's over 850 million people, well, the one thing that kidney disease. And burden varies. Its capacity, I think you should try and mute everyone. And what is happening is that the rates will vary in the country that you're in. So how rich your country is, how well developed health community is, and your cultures, what are the political factors, all these things will determine how frequent you have kidney problems, how your capacity to be able to detect them, the ability to be able to deal with them as well. So basically, there are two types of kidney failure. You have the acute, you have the chronic. Most times, what we're talking about is the chronic. But it's nice to know also about the acute. The acute is the one that happens suddenly. It happens consequent on an event that you can identify. Somebody had an accident, lost a lot of blood, the kidney failed. Someone had very bad diarrhea and vomiting, lost a lot of fluid, the kidney failed. Such things, usually you can identify what caused it. And you can treat that cause, and the patient survives. Patient survives and usually recovers without any sequelae. So usually most acute, if you don't die from it, you recover. So usually we don't talk too much about it, but it's nice to know that there's acute. But most times it's the chronic. Once we say you have chronic, by definition, it will never go away. And if you don't look after it properly, it will get worse with time. And to get to an extent that you would now need to help that kidney. That help is either by dialysis, transplant. Neither of those two things are cheap. So you had better know the things that cause it, know how to deal with those things to prevent you getting to the stage where you now need to look after kidney, either by dialysis or transplant. And it's important for us to know because we Black people, we people in Africa, we are more prone to kidney problems, and I'll show you that, than people from any other part of the world, more prone than white people, more prone than Asian. The things that can cause the kidney to fail are very common in Africa. And not only are they common, they're even more common amongst us. So hypertension is more common in Black people. Diabetes, surprisingly, is more common Black people as well. Unfortunately, most of these conditions that cause kidney failure, even in the early stages of kidney failure, you find that the symptoms they cause are so mild that we don't know. So unless you come for screenings like this, where they check your blood pressure, they check your blood sugar, they check your urine to see whether there's protein in it, you might never know. And that's why you find that almost 80% of people who end up requiring dialysis, we don't know until the stage where they need dialysis. Meanwhile, we could have detected it much, much earlier, where, applying the appropriate measures, we can at least slow down. And that's because you'll find that this is what we call the iceberg. When you have an iceberg, and you see the top of it, you don't realize that there's more below the surface. So the people we detect are only that small iceberg. Those are the ones in what we call stage 5. But there are many people in stage 1, stage 2, stage 3 that have the early stages, and that is the stage at which really we should stop. In the past, usually the focus was on treatment. Okay. So you have kidney failure, you need dialysis, you need transplant. But now we're realizing that, one, because the number of people who have that kidney failure and need dialysis, many more people haven't reached that stage. So what can we do to help those people who haven't reached that stage? And that's what a lot of which we'll be talking about today. There are all kinds of new treatment events for delaying developing kidney failure and getting stage where. So what are those barriers to these new treatments? One, people are not aware that those treatments exist. If you don't know about something, you can't use it. Two, even if you don't know you have kidney failure, you can't be looking for new treatment. Sometimes it's lack of confidence. Sometimes even the doctors don't even know these new treatment. But most importantly, rather high treatment. Anything new always costs a lot. You find that very often it's beyond what. And we know that kidney is a major worldwide public health problem. Responsible for an increase, the risk of dying and feeling sick, and it costs a lot to fix. We know that 10 to 16% of adults have some state of kidney. The average is usually about 13.4%. And we find that is increasing. So in 1990, it was the 25th leading cause of death in the world. By 2005, it became the 21st. In 2015, it was the 17th. Now it is the 8th leading cause of death. Well, and it is ahead of TB, HIV, malaria, all these other things we make a lot of noise about. Kidney failure is more likely to cause death than any of this. And it is the one that is growing the fastest between 1990 and now. And if we go on at this rate, we estimate that by 2050 to 2040 to be the 5th commonest cause of death. But more importantly, 1/3 of us are prone kidney failure. That is 1 out of every 3 of us. And what are the reasons why we're prone? That is because we have hypertension. You get to see that hypertension is very common. Once you're over 50, 50% of us have. By 60%, by 70%. Diabetes, over 10% of people have that. We're all not farmers again, not riding our bikes, all living sedentary lives. So we're all becoming obese. Obesity, as you see, those that smoke, they're over 60, you get to see risk are there. And then people with a family history, if somebody in your family has had kidney issues, the likelihood that you have is much higher. Then, of course, if you're a Black person. So you find that by the time you look at all this, so almost every one of us in this room. But looking at the statistics, we've said 10%. But that statistic doesn't quite reflect how severe that problem is. So if you are between 65 and 74, 20% of men, 1 out of every 5, and 25% of women, 1 out of every 4 have chronic. So we're saying 10% before, but in this group of people, 20 and 25. And if you're over 75, 50%. So that's how common it is. And it affects all ages. You can't say it's only a disease of the elderly. You find that, particularly in our own environment, people that are affected are generally much younger than others. And so these are studies that have been done all over Africa. And the average age, the average percent, almost 40%. I'm going to stop here a bit to look at this. But these are the common things that cause kidney failure. They include hypertension. I've said easily over 50% of people over the age of 50 have hypertension. 60% over 60, 70% over 70. So hardly, I'm sure almost all of us in this room, except the very young. But the unfortunate thing is that only 1 out of every 3 people with hypertension know that they have it. So 60 or 70% of people are going around with hypertension, not realizing that they have it. And if you don't have it, you're not on treatment for it. Now, for even those who know, only 30% of them, because somebody has wrongly told them that, look, you have hypertension. It's like headache. You take tablet for it. Once your headache has gone, you're fine. That's not it. If you have hypertension, it's for life. The majority of people who have hypertension don't have symptoms at all. They don't say because I feel well, okay, I don't have hypertension. So hypertension can affect everybody, and most times it is not symptomatic. You won't have any symptoms at all. And then even those, I've said only 30% know they have it. Only 30% of those who know they have it are on treatment. Then only 30% of those on treatment are well controlled. And most times it's because of the cost. I was speaking with a colleague. This one is a doctor himself. And he said when he started off with Exford cost him only 2,000 naira. Now he's spending 40,000 naira, just one tablet, for simple hypertension. Meanwhile, our minimum wage is what? 30,000 naira. So you can imagine if someone who's earning 30,000 has hypertension. And that's why this is one of the most common causes of kidney failure. Diabetes. I've said 25 years ago, only 2.2% of Nigerians had that. Now, over 10%. And even if you look at certain groups of people, the people in Lagos, people who are obese, people who are well endowed, you find that the prevalence of diabetes amongst them is even as high as that. And only 50% of those who have diabetes know that they have it. That means only 50% of them are treated. So many people are going around with diabetes that don't know. And between these two, some of the commonest causes of kidney disease that we see. Then the third is chronic glomerulonephritis. This is the long term. But this is usually an inflammation of the kidney that follows chronic illnesses. So things like hepatitis. If you have hepatitis and you don't know and you don't treat it causes your kidney to fail. If you have worms and you don't treat it, you have, sore throats, you have skin infections. Any chronic infection that you don't treat properly can lead on to kidney failure. So you find, particularly amongst our young people, this is one of the commonest reasons. Because hepatitis B is common, about 15%. Hepatitis C is common, about 8%. HIV is common. Maybe it's come down from 5% to about 2% now. And all these things, if you don't recognize and you don't treat properly, risk of. So these are things that are common in the environment. But there are others that I always use an opportunity like this to speak. And they include things like bleaching creams. Most of these bleaching creams contain mercury. And mercury is a heavy metal that if it is chronically applied even on the skin, because the largest organ in the body is the skin. So if you apply it all over, for the sake of becoming yellow pepper, you're actually taking enough of it chronically to cause the kidney failure. And studies have been done. We found that the prevalence of kidney failure was much higher in people who used bleaching cream. Then analgesics. So things like paracetamol, even simple paracetamol. If you take 2 tablets of paracetamol, take it 3 times a day, and take it chronically for 2 years, I'll show you your kidney. So you find the average taxi driver, he has worked all day, he's tired, goes to chemist. The chemist, so yeah, give me a shampoo. Shampoo with paracetamol, ibuprofen, diclofenac, he puts everything together and takes. By the time he's done that 3-4 months, you start wondering why his leg decided to swell. So, abuse of analgesics. Simple paracetamol, but particularly the non-steroidals, things like ibuprofen, Nurofen, diclofenac, all these things. Particularly in people who already have some level of kidney health, please do not use them. So if you are hypertensive or diabetic, unfortunately, that's the time you now have back pain and knee pain and all kinds of pain. Go, your doctor will write diclofenac. Please don't use them. Because almost certainly we develop some kidney disease or the other. Then all sorts of other things. Of course, fibroids, women, prostate, and all those things can cause obstruction. Obstruction can also lead on to. Then toxic nephropathy. Must not live without talking about that. These are those of us who go and use agbo, homo. If you go under the bed, remember once I had to visit another person abroad. My stethoscope dropped. When I picked up the thing, I found the keg under the bed where the person has been taking his agbo every day. Then this thing will kill your kidney. Because you never know what is inside all those things. In fact, in Taiwan, one of the more common reasons why their kidneys fail. There's actually an entity known as the Chinese herbal nephropathy, where even all these Chinese herbs, all these bitters and things, you need to be exceedingly careful. I will talk about most of the others. These are the ones that I think are relevant to talk today. But a few other things that I think are important. So the bigger that you are, the greater the risk of your developing kidney. So you find that your BMI, which is a measure of how obese you are, you find that the greater the incidence of protein in the urine. Protein in the urine is always a marker of kidney damage. You should not have protein in the urine. So not even trace. By the time you're having trace, you're having 1+, 2+, you know that it's a problem. And you find that the bigger that you are, the greater the incidence of protein in the urine. So if there's one thing you can do, try and keep the weight trim. Smoking is another thing. You find that when you smoke, it actually impairs, aside from all the other things it does, increases your risk of bronchitis, cancer of the lungs. It also impairs blood flow to the kidney. One of the things that can ultimately lead on to drinking. Find that the more alcohol you drink, the more the risk of developing kidney failure. Most of these things that we inflict on ourselves are things that if you are not careful can lead on to kidney failure. And a few that we may not know, eating too much protein. So just sitting down and eating a kilo of steak, finishing a whole chicken, exposing yourself to the risk of kidney. And then this is what I mentioned before, analgesics. So this is what a normal kidney looks like. This is what it looks like in somebody who has used this person. But then the other things, we've mentioned, of course, diabetes and hypertension. So worldwide, those are the two commonest causes. Because more common with those who are socially deprived, those who have or you smoke, you're obese. But then also we know that the older you get, the more common it is. You know, it's slightly more common in men than in women. But then your ethnicity is also important. And I'm going to take some time out to also talk about it. So you find that in the US and the UK, when they went and analyzed the number of people that had kidney failure, they found that the Black people, the prevalence of kidney failure was 800 per million population. But among white people, it was less than 200. So it means it is 4 times more common amongst Black people. And it's the same in the UK when they look at the white people and the African Caribbeans. So there's something in us Black people that makes us grow. And they said maybe it's because of poverty, ignorance, literacy, all these things might have some role to play. But in America, where they're all exposed to the same social dynamics, they found that that is not the case. What we put it down is to this gene. So there's a gene that we as Black people inherit, which we call the alpha-lipoprotein 1 gene, which if you inherit it, it increases your risk. And you find that that gene, which prevalence is mainly in the West African parts of Africa. And that's why you find that when they actually analyze the gene amongst African Americans, that's Black Americans, we West Africans, East Africans, European Americans. While the European Americans, they don't have it. The African Americans have between 10 and 15%. The East Africans have between 0 and 16%. But we West Africans, the time you add 38 to 8, that's 46%. That's almost 50%. And those who don't even have it, we carry the gene such that we pass it on to us. And that's why when you look at even the map of Africa and the prevalence for the kidney disease, you find that the highest prevalence is that west part of Africa, where the prevalence is about 16.5%, followed by Central Africa, which is contiguous to us, 15%. Then South Africa, which is 12.2%, East Africa, which is 11%, and the list are the Arabs. So the Arabs are different people. They're not the same people at all. Because there are things that we see that. Then there's some that you have not been able to find. So we call them chronic kidney disease of undetermined origin. Not able to say what caused. We find that it tends to occur, you've excluded hypertension, you've excluded diabetes, no glomerulonephritis, no obstruction, but yet these people have this disease, and it's common in certain areas. And in those areas where it is endemic, you need to have lived there for more than 10 years. When we look at it, the kidneys are very solid. And the things that have been identified are tend to occur in places where there is a lot of heat, stress, and as a consequence, dehydration, where there's low socioeconomic status, where there's genetic predisposition. So these are all things that come very frequently. So you find that here is top 10 countries with unhealthy air quality. And you find that yes, Bangladesh, Pakistan, blah, 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 but number 10 is. And when they say, what are the 20 worst cities for air pollution? The worst is only China, Nigeria. And then Kaduna, and then Ebun. I'm sure this will be proved now that they have 24-hour power supply. And then one here in Nigeria. So in this top 20, there are 4 Nigerian cities that are identified. And these are all things that make it likely that you will be so exposed to end up with. I mean, of course, we know what happens in the night. All kinds of pollution, illegal bunkering. And we know, studies have now shown that when you're exposed to all these chemicals and solvents, it increases your risk of developing kidney. And then others, they said the average woman wears about 500 chemicals every day. Then you put the lip gloss, the mascara, the eyeshadow. Somebody actually counted that there are over 500 now. And they say the killer cosmetics, the potential risks. So you have 200 times the risk of developing chronic illness, including kidney failure, liver damage. So we need to be careful with our exposure to. So looking at our health statistics, like I said, kidney failure is quite common. This study was done by Professor Lassie and Ebun. They found that hypertension was, even in that rural and semi-rural area, 26%, diabetes 6%, obesity was high, kidney failure was over 10%. When Wako did it in the Northeast, he found almost 18% people that had it. And we know that, yes, it's common. Despite how common it is, we don't have the capacity to treat. So even though we're 17% of the world, when we look at the total number of people on dialysis everywhere in the world, only 1% of those people are dialyzing here. And this is despite the fact that we're actually 2.6% of the population of the world. Nigeria is actually the 7th most populous country in the world. And we estimate that if we continue at the rate we are going, by 2050, we will be the 3rd most populous country in the world. Only China and India will be more populous. We are going to overtake US by 2050 if we continue at the rate. So like I said, we are 2.6% of the world. But then when we look at the whole world's economy in the chart, you find that the whole of Africa is less than 1% of the economy of the whole world. The United States is probably about almost 25%. China almost 15%. The whole of Africa is only less than 1%. And Nigeria is almost about 0. Yes, we are the largest economy in Africa. True. That large 2.7% population, only 0.4%. So that tells you that yes, we're just large for nothing. Yes, we say that African wealthiest individual. So South Africa has the largest number of people, $1 million or more. So that's 1 billion naira now. They have over 46,000 people. Egypt. Nigeria has over 15,000 such billionaires. And if you look at people who are billionaires in dollars, you find that Nigeria has over 20 people who are billionaires in dollars. But then we also have the largest number of people with extreme poverty. That's why they say Nigeria is now the poverty capital. So it's estimated that almost 100 million Nigerians out of that 200 million cannot live on more than $2 per day. But worse still, the distribution of that poverty. This is looking at where in Nigeria that poverty exists. You see, it's almost like a two-state situation, where almost the whole north, in Zamfara, 92% of them are poor. In Katsina, 82%, in Jigawa, 88%. In Lagos, less than 10%. So you find that it's almost skewed in a way that there are fewer people that are poor in the southwest, somewhat towards south, many more people. So yes, there's a lot of poverty, most of that poverty well distributed. So that is why there's a gap between the number of people who have kidney failure and the number of people who are accessing care, which, like I said, is the thrust of World Kidney Day today. And this chart just shows it. This is a study that was done in LA, where they looked at all the patients they had managed over. So they found that about 1,200 people with kidney failure had been managed in that hospital. Of course, they were only able to retrieve records for 700 of them. More were men. Out of the 700, only 500 of them were able to afford dialysis. Out of the 500 that accessed dialysis, only 38 of them survived more than 3 months. And why? Then they have professors there, they have dialysis machines there. Most times, because people could not afford to access it. Just afford one, 2, 3 sessions. And once you get to the stage where you need dialysis, they want to do continually indefinitely. For those who have access at all, 90% of them have died. So we don't need to have kidney failure, whether you do dialysis. If you don't do dialysis, no matter what alternative treatment you have. And overall, 87% of them dead within 1 month. Because it just not afford. They estimated it just 160. Yeah, statistics might be slightly different. But I can tell you that last year, and less than 5% of patients died in 1 year. So, 95% of it. Because we are dealing with a privileged class of patients, whether they can afford it or are being sponsored by different companies who are assisting in their care. And we know that this is geared on what we call sustainable development goals. And of those sustainable development goals, goal 3 is geared towards health. And it says ensure healthy lives and all at all ages. Now, if I want to do that, you have to make sure that everyone has access to care, access to safe water, to safety without the risk of being kidnapped. But also more importantly, access to affordable and essential medicines. If ordinary antihypertensive is now costing over 40,000, can imagine how many very poor people without able to access. And we say that the people goal of the healthcare system that should keep your people happy. Of course, when they say we have the capacity to treat them, and they should be able to treat themselves without going into financial penury because of the cost of care. And while we are assessing the health system of the country, we want to see how easily accessible is healthcare. What is the quality of that care that you're giving, and how relevant it is. No point in providing something that either people cannot afford. And that's why we feel that national health insurance we still need to do a lot. Less than 5% of people are registered in NHS, and over 70% of us are still having to pay out of pocket care and access. We're not spending enough on health. There was the so-called Abuja declaration, which said we spending about 15%. This is what Nigeria has done over the years. We're still spending under 5%. And that's why you find that we don't have enough doctors, and speak to that please. Because our doctors are leaving. So attrition. So we all know about that. They say Nigerian nurses generally leave your workforce. It's there. And Nigerian nurses are now the third largest group of people after Philippines and India in terms of number. And the number in 1 year went from 7,000 to over 10,000. So it grew by almost 40%, 46.6% in 1 year. Same with doctors in the UK. You find that Nigerians are third after India, Pakistan. Total number of Nigerian doctors is now over 10,000. And if you look in America, looking at specifically doctors that look after the nephrologists, for those who train in different countries in Africa, who are now practicing in America, find that Nigerians have the highest degree. And that becomes even more significant because when you look at different number of nephrologists per continent, you find that Africa has the least. And as with the previous chart, you find that the distribution of those doctors' capacity also varies. So you find that Southwest probably has the best capacity, followed by South, South, and Southeast, Northwest, North Central, Northeast always seems to have the worst. And then, of course, Lagos and Abuja always seem to do better than all of them. In fact, the president of Nigerian Prescribing Medical College, he said that over 40,000 Nigerian doctors practicing in different parts of the world. They've trained over 80,000, 40,000 hospitals. But more importantly, they're even now finding it difficult to find people to train. Because all our young doctors are all leaving as well. So, of course, there is marked disparity. So, even despite the fact that we don't have enough, we now look at different parts of the country, just like the previous chart, you find, the worst statistics are always in the north, and the best statistics are always in the south. So, this is looking at vaccinations to find that the darker green places now, people are doing better than the lighter green places. And in terms of how wealthy you are, so if you are poor, you do worse off than those who are rich. Of course, if you are in either the urban area is always better than rural area. And that's what leads to situations like the herbalist, this is Dr. Truman, who can treat so many problems. So he treats people with swollen body, which will take it as kidney failure. But he also treats people with cut kidneys, bad luck, and our Lord knowing our pension, he has gone nuclear. You can see it with his computer. Then our prophets, holy prophets, ministries. For all kinds of, they have to pay for whatever it is. Also, the quality of some of our hospitals. So this is the Makina Royal. See the little doctor in the front. The one that obsesses me even more is that now we are not taking advantage, and doctors are running severe. And you now have doctors coming from, you now have Turkish hospital, Indian hospital. The one I saw there, told is, what do they call it? Coptic hospital. And if it's somebody who lives in this country, if it's that good, come and treat me. Don't like it. Meanwhile, we are running, seeing what we are seeing and coming to it. So you can imagine this big spirit that wants to give you small child. So you find, because of that, people go to patent medicine stores, go to traditional healers, rather than going to the hospital. And then there is training for us to pray and everything. My own concept about it is, prayer won't work, prayer won't function without work. I'm sure there's an appropriate quote in the Bible that says that. So when you look at all the different countries involved and how often they pray. In China, 24% of them pray every day. In England, maybe about 6%. The country with the highest number of praying people. So we don't give failures. We actually estimate that the number of people every year that require dialysis transplant is usually 100 for every million population. We have 220 million people in years. So we need that means that 22,000 people every year need dialysis. And yet when you look at the total number of people on dialysis, I saw the previous chart where I said 90% of people who didn't have dialysis but dead in 2 years. So that is why we find that kidney failure is one of the more common reasons why people have died So of course we've had great capacity to do different things. So we've been able to do peritoneal dialysis. Hemodialysis started almost over 40 years ago. The over 240 dialysis units, like I said, many of them are just urban areas, very few in rural areas, more in the southern part of the country than the north. So this is just the distribution of China, more and more in this southern part. But we know that kidney failure is a major problem. We don't have enough people. Dialysis units are few. Then in the urban area, most of them are small, they're not well known. And most patients we see are already at a stage where they need kidney support or dialysis by the time we're seeing them. And so it's not surprising saw in child for defect. A lot of people, unfortunately, are not surviving. And these are the reasons. Dialysis costs about 150,000 naira. So each session of dialysis is now about 50,000. And ideally, you need 3 sessions. That's 150,000 every week. Multiply that by 4. That's 600,000 a month. Multiply that by 12. That's about 7 million spending just on dialysis. It doesn't include the amount of spending on drugs. Doesn't amount, include the amount of spending on tests. And very often they need admission. You add that. There's no way if you have kidney failure, you spend less than 10 million every single year just sustaining this. And then transplants, we now encourage them to do. The price keeps climbing every day. Now, if you're going to do a transplant, you need to 17.5 and 20 million. And then it doesn't mean that you've got to transplant that again. I said, somebody told me just this morning, I wanted to validate this slide. No, it's not about that. That costs them about 300,000 every single month just to buy the medications to sustain that. But transplants have been around quite a bit. It's going to be 70 years that first successful transplant has been done. This was one that I've done over 50 years ago, where the patient is still alive, where a 6-year-old boy was given the kidney, dead person's kidney. He's still alive today and doing well. But then, if you look at the world and say, okay, where is transplant being done? Deciding to shape the world as big as transplant activities, we find that Africa is almost shrunk, whilst America is bloated and Europe is bloated. This shows the amount of transplants being done. Most parts of Africa hardly much is being done. In fact, in 2021, when we looked at the number of transplants done that year, only about 1%, the total number of transplants, of course, mainly kidney, but only about 1% of those transplants being done in Africa. These are the countries in Africa where transplants are done. For South Africa, Sudan, Nigeria, of course, are the pioneers in West Africa, as Nicholas Philip pioneered kidney transplants about 25 years ago. You know, its cost is an issue. Altogether, over 1,500 transplants. But the problems are because the high costs, the fact that we don't spend enough on healthcare. Healthcare facilities don't have the capacity. All these are reasons why we're not doing as well as most other countries in Africa. So what have we done is started dialysis. So I can tell you the date on the 6th of August, the year 1998. I was the very first patient that we dialyzed. And this is what has happened. Find that every year, see more and more and more. 2023, we actually saw over 200 patients because of that year. And in terms of transplants and numbers that we've done over the years, last year we did 42 transplants. And you find that most of them are young people. And as you saw, we said there are more men than women. But also partly because as society, it's more likely to want to spend money for the male, the female. But one concern, of course, which one must use this opportunity to also emphasize, the fact that in the process of doing a transplant, you need to take a kidney. As a policy, we insist that the donor must be either genetically or emotionally related to the kidney. So we don't take kidneys from somebody who wants to buy a kidney. So of course we have measures in place because there's a declaration of Istanbul, which was that we should avoid the situation that we are going to buy kidney, where are you going to buy it from the poor and vulnerable people. Some of whom will have given one kidney and will come and want to give a second kidney. What is the license? What's the implication of that? So, I mean, this is something that we put together over 15 years ago. I happen to be one of those who put the Istanbul Declaration together. Look at small black man there. And we now have the Health Act, which prescribes all kinds of fines, jail terms to those who abuse this. But we feel that the jail term and the fines are not enough to serve as a deterrent. So there are measures in place. I know the federal government has put together a committee to try and see to it that we actually enforce that deterrent component. So in terms of kidney transplant, we know that the barrier is the high cost. Not just on the transplant, follow-up care, cost of maintenance and operation. So this is something that we feel government needs to step into and do something about. Cost of drugs. Why are drugs expensive? Because you still pay duty. There's no reason why you should be paying duty on drugs. I mean, I heard recently that even the president is looking into it. You need to do something about it quickly. Because we must accept that the provision of universal health care is a fundamental human right. And it's not a matter of should it be, it has to be. It's not a matter of if, but how and when. If any private government looking to see how can I ensure that care, appropriate care is provided to citizens. And then we should develop the full capacity to deal with full waste of water. So whether it's peritoneal dialysis, some of which we believe should be cheaper if we produce waste care. We should have the capacity to do hemodialysis everywhere, not that you have to come to major urban centers to do it. And if you have stones, ways of dealing with it, but even the stones are not properly managed, the kidney will fail. And all these services should be available for all costs that are affordable and at locations within which both urban and rural areas. So the less privileged government has public hospitals need to develop that capacity and provide it appropriately. And if and when it becomes widely available, free availability will drive down the cost. Anything that is scarce will be expensive. When it's now readily available, the cost should come down. And then we should look at alternative solutions. Why do we have to import fluids? Why do we import the dialyzer? Why can't we manufacture those things locally? And if we do, ideally that should help to bring costs down. But also important, what we're doing today, we should screen and diagnose early. So if you are diagnosing early, you diagnose at the stage where you can make a difference. That is not to the same way the person needs dialysis. All you need to do is make sure that you are providing the medications and you are encouraging the person to use those medications for hypertension or diabetes properly. And that involves primary, secondary, and tertiary prevention. Before the person develops kidney failure, before he develops hypertension. So what are the things that cause hypertension? So maybe encouraging them to be less stubborn. When it now develops hypertension, we are controlling the hypertension to make sure that now doesn't develop kidney failure. When you have developed early stages of kidney failure, we control it to make sure it doesn't get to the stage where it now needs dialysis or transplant. And then, of course, if you then get to the stage of dialysis, make sure you provide that, make it affordable for him to access. But most importantly, as NHIA must now be re-engineered to make sure that it can provide care to many more people at affordable costs. So what are the things responsible for optimal kidney care? Limited policy focus, how many days focus on it and develop policies that are appropriate. We're not educating our patients and the providers appropriately. I hope we and Nicholas are providing that education for you today. Then lack of resources for high quality care. And then limited access to affordable medication. So these are things that the federal government needs to look into to ensure that we help to reduce the current blooming epidemic that we're seeing. So who are the people that should be screened? Because if you have hypertension at the time of your diagnosis, you should make sure the screen is make sure you don't have kidney failure. And then every year subsequently, if you have any cardiovascular disease, have heart failure or had a heart attack, you need to screen the patient and have kidney failure. Because if you have any chronic infections, in anybody who's elderly, now is 60 and more, because pregnant women are lucky, when you go through antenatal care. They also have the benefit of having their blood pressure really checked. And then if you have any person in the family who are kidney problems, please ensure that you just screen. And the things that we know that can slow down progression would be strictly control your blood pressure. And there are certain drugs that we know are better for controlling the blood pressure, preventing progression and others. Unfortunately, those drugs are the ones that are more expensive. All your valsartan, caprisartan, all these so-called angiotensin receptor blockers. They're newer drugs, but we know that they're better drugs to use for people who have hypertension to prevent your kidneys from failing. Because if your cholesterol is high, you're diabetic, we want to encourage you to not eat too much of protein, avoid nephrotoxic agents, upset to non-steroidal ibuprofen and others. And of course, you are smoke, we stop. And then, of course, treatment. And are you okay now? Also, water. So we know the person can lose up to 90% of their function, and you won't know. So by the time you know, 90% of your kidney function is gone. And there's simple tests that can be done. Your urine test, your blood test, all these will detect it early before you get to the stage where you now need dialysis. And things to look out for, of course, your feet are swollen, if you're having difficulty concentrating, you get easily tired, your appetite is poor. It's also important if you pass urine and you notice that your urine foams, then you need to check to make sure that it's not protected. And then we have the so-called 8 golden rules to reduce your risk. You should keep fit, be active. Instead of going to stadium to try and jump, just walking. Try and count 10,000 steps if you can. I know that will be difficult for most of us, but try between 5, 6, 8 if you can. And these days you have these watches that help you count the number of steps. Just move and find that will help. Eat a healthy diet. And there are things that you can do. Cut back salt and exercise. Make sure that you get so much that you can eat. If you're diabetic, you need to make sure that you eat appropriately. That. Most importantly is to reduce salt. Our diet, particularly in Africa, is particularly high in salt. And maybe should be looking more towards 3 to 4 grams of salt. Of course, if you have sugar, control it. But notice that only 50% of those who have sugar problems know they have it. So unless you check, you might never know. Make sure you when you go to hospital, you get a doctor to check. So, of course, check and control your blood pressure. Make sure you take appropriate amounts of water every day. That means at least 8 cups of water. Don't take less than 2 liters of water. Don't smoke. And then take any drugs that you don't need. Don't take at home. Don't take at home. Don't take anti-inflammatory painkillers. And then any opportunity you get, make sure that you check the kidney function. Also, if you're elderly, if you're obese, if you have hypertension of diabetes, and you have a family history of kidney. I always link this my favorite couple. It's exactly 24 years before I did a child. And this gentleman gave his kidney to his wife. Both of them are alive and well. Thank you very much. So I know you have questions. So I'll take one here first, and then we'll look to see whether there's some online those that have joined us on. But I think it's an opportunity for you to ask all the questions you always wanted.